Good afternoon, everybody. I'm delighted today. I'm going to be joined by Dr. Vivienne Hall from the Zita West Clinic. She's running a little bit late, so she will be on, but I'm going to start by taking some of your questions, which will be really, really good. And I'm going to go through as many as we can because we have an awful lot. So I'll do my best to go through them. And she must have raced ahead to wait for her to come up and answer your questions.
Hello.
Vivienne, how are you?
Good, thank you. How are you?
I thought you were running a little bit late, so I was going to sort of storm ahead.
I caught up. There we are.
You caught up. Well done. How's everything going? You busy?
Good. Yeah, we've been busy. Yeah.
Great. Okay. It's funny because I'm in London at the moment and it's like the whole of London is out. There's people in the streets, they're in the parks, everywhere. It feels that things are lightening up a bit, doesn't it? Long way at last. Yeah. So I've got a lot of questions here, Vivienne, and we'll get through as many as we can. Mm-hmm. So some of the questions are asking about consultations when you're starting IVF. So one here is what do you need to decide about when you do IVF and how long you can postpone IVF for?
That's a very broad question. It depends on what your history is, how old you are, how long you've been trying, what investigations you've had so far, and what were the results of those investigations. There are some young women who've been trying for a year and they do a test for something or other, and it's the only option for them is IVF, so that's the way forward. There are other people who may have been trying for a little bit longer and have done some investigations. Nothing spectacular comes out of the investigations saying you must do IVF, so we can delay it a little bit. So it very much depends on your age and the tests that you've done so far.
Yeah, I think as well, it's fair to say that when people come to the clinic, it is an individualized approach and not everybody is ready for IVF. And so it's looking at everything else that's going on. Some of the couples that I see, and the same with you, they're moving house, they're moving jobs, they're traveling, they've got sick relatives and things. So, you've got to be able to focus, haven't you, to sort of really help you. And some aren't ready to start IVF. They want to try a few more things before they go down that route. So I think the important thing is definitely working within a timeline, isn't it? And having a plan of action. Yeah. Another question here. What's the difference between a fertility assessment and a consultation?
Okay.
If you do tests as part of the consultation, which is better?
Well, it used to be that a fertility assessment was something like, perhaps, if you're talking about a sort of fertility MOT, it would be an ultrasound scan to have a look at a basic pelvic scan, to have a look at the uterus and the ovaries, give you an idea of your egg reserve, and possibly a sperm test as well. So they would be pretty basic tests on which you could base a conversation. Yeah. A consultation is completely different. And pre-COVID, we often combined a fertility assessment with a consultation. Yeah. Because you'd be able to come into the clinic, we could have a chat, go and do a scan, then come back and make a decision based on the scan as to what the next steps would be. These days, we tend to do it separately, and patients come in and have a fertility assessment and then book a virtual consultation. The consultation really, ideally, is done when you've got some basic investigations done and we can really spend the time discussing the results and what your next steps would be.
Yeah, and I know that the three doctors, you, Simone and George, the first consultation is really detailed, isn't it? Because that really lays the foundation to how we're going to progress somebody through an IVF cycle. And I think a lot of women that have had failed cycles come to us, don't they? And then, it's working out what we need to do differently this next time round, which is going to optimize their success.
Yes, I think the most important thing about a consultation is actually the questionnaire that we send out, and most clinics do send out a questionnaire before you come to the consultation. So you have time to actually fill in the consultation calmly and quietly a few days before the consultation, so you can remember everything, look things up, what happened then and what happened then. fill it in as fully as possible, because that saves time during the consultation. And also, I certainly look at these questionnaires long before the consultation. And if there's anything that I think, you know, well, that's interesting, I've got time to look it up and have a think about things. So the pre-consultation questionnaire is very detailed, very important. You know, sometimes everyone knows that when you're having a medical consultation, something like, you know, 30% of what is said is just forgotten immediately.
Yeah.
And it's very difficult on the spur of the moment to remember, well, what did I do next? And what was the next operation? What did I do then? So you fill it in beforehand, especially the family history and your general medical history. I actually look at every consultation. I love first consultations. Well, I love all consultations, but I love first consultations because for me, it's like a little mystery. And it's time to sort of get all the information together and start investigating why this couple, or this lady, is not pregnant. What's the problem here? And based on that consultation, we can either go straight ahead with treatment or offer treatment or do further investigations to clarify the situation. And the beauty of that is that oftentimes by doing more investigations, simple investigations, you might find that if we can correct simple things, you can get pregnant spontaneously, naturally, yes, without having to have IVF. So I'm always intrigued that there are some patients who come along and say, I've had IVF because I had unexplained infertility. And then when you dig down and very deep, I mean, I saw a patient recently who had IVF for unexplained infertility, but had never had a test to see if her tubes were open, and who had, her husband had abnormal sperm tests. And I thought, well, what's unexplained about that?
Yeah.
You know, it's not true. Explained. So yeah, if it seems like we're doing too many investigations, it's because it's important. And I think it's much more important to know as much as possible before you start treatment, so that you don't waste a treatment cycle. And
yeah, no, I agree with you. And I think with our consultations as well, because of the holistic approach, we look at lifestyle, we look at emotional factors, we look at stress, we look at all sorts of things that is probably different from other clinics. So as a team, we're able to sort of like look at what we can do emotionally to help, what we can do nutritionally to help, etc. So it's a really important foundation, isn't it, to how a cycle is going to progress. Okay, I've got another question here, and somebody's just written a lovely little note, Vivienne, that they came to see you and they're very hopeful after 3.5 years, so that's good. So is the Zita West clinical nutritional consultation before the doctor consultation? As surely you would need a few, to make a few changes in nutrition to make an impact on your IVF before you do fertility tests. Well, I can answer that, Vivienne. The doctor's consultation is first because that lays the foundations down. The next, you know, we get as soon as we can in within a week, we try and get a nutritional consultation, which is now done by Zoom, so that we're able to sort of say or flag up the different things that that are needed. So it is important. And again, for many other women that come to our clinic, unlike 10 years ago, and you must see this in your practice as well, Vivienne, that women now, they are on supplements. They know a lot more about lifestyle and what they need to do. So very often it's just tweaks and really getting the nutrients and the supplements in before before they start their cycle.
If they do need to do IVF, indeed they do.
Yes.
And the thing is, we have a little waiting list, not a long waiting list. And that is good because it gives us time to do all of that preparation. And make sure that when we get to your cycle of IVF, if that's what you need, then you're in tip-top condition and we get the best eggs and sperm possible. And I think as well, I think it is important because I think with the whole fertility world and the way that we do fertility in this country, that you go and see your GP, you've been trying for a year, and really you're straight in a fertility clinic that's looking at doing IVF when there are things that you can do beforehand. And people, and lots of women and men are not ready to do IVF. You know, they need a bit of a time to get their head around it. Absolutely.
When should you have a consultation if you want to start IVF in May or June? Well, we're in April tomorrow, aren't we?
Yeah, well, we're already booking cycles into June.
Right. Okay.
We're pretty booked all of April, the first half of May.
Yeah.
And we're beginning to book up the end of May now.
Right.
So,
okay. So it's, book in as soon. And I think as well, I think I always say to my clients, I don't know what to say to yours, that very often just because you're having an IVF consultation doesn't mean to say you're doing IVF.
Absolutely. Yes.
Then it can be that you do this consultation and you say, right, we're in April now. If I don't get pregnant or I haven't made any, I'm making the changes I need to make, I'm going to give myself to July or August. And if I'm still not pregnant, then I'm going to do IVF. So all the groundwork has been done, hasn't it? And I think,
but a lot of it comes from the consultation and what comes out from the medical history. For example, if you fill in your medical history form and you mention, and you hadn't really thought about it or mentioned it to anyone before, you just thought, well, that's it. Oh, well, my mum had a DVT and my sisters had a thrombosis as well. That will trigger alarm bells and think, well, hang on a minute, what's going on here? Is there a history of blood clotting disorders and that sort of thing? Or if you say, well, I've had chronic infection and my tubes are blocked, and we might actually start doing some more investigation to see whether there's a chronic infection in the uterus. Before we actually start, because we need to have everything ready for an embryo to implant. And the beauty of it is, if the problem is that there's a chronic infection somewhere, or a microbiome problem where there's just not the right environment for an embryo to implant, and we can address that, hopefully you'll get pregnant without having to do IVF.
Can you just explain a little bit, Vivienne, about the microbiome, because it's becoming increasingly discussed on forums and with women, and gut health and vaginal health is all important.
Well, of course it is. And I mean, there's plenty out there to read, and I'm sure everybody's already read everything. But the microbiome, the bacteria and viruses and fungi in your gut, actually, shouldn't be thought of as something that just happens to be there. It's actually an organ, it actually has a role. So the bacteria in your gut actually are necessary for you to survive. They help digest food, obviously, but they help vitamin formation and warding off other nasty bacteria. So you have to have a balanced microbiome to be healthy, basically. And you can help that by taking probiotics and eating a very varied and balanced diet, lots of fruit and vegetables. And when you have an unbalanced microbiome in the gut, that can actually affect the microbiome in other parts. So it can affect the microbiome in the vagina. It can affect the microbiome in your sinuses and your nose and that sort of thing. So the gut is the main microbiome, but there are sub areas of the microbiome that actually we're paying more and more attention to. And
but we can test for that as well.
We can test for it, and we can test for sort of chronic niggling, subclinical, so no particular symptoms, but subclinical chronic infection that doesn't give you any symptoms, but it causes inflammation and may stop an embryo from implanting. And oftentimes all you need is a course of antibiotics for you and your partner. And that will clear everything, ready for implantation, and that's it.
Somebody's asking here, how do you check the microbiome of the uterus?
Well, I like to check it by doing a blood test, a test called Hidden C, which is a test, it sounds a bit gross, but it's a menstrual blood test. So you actually put a little bit of menstrual blood into a test tube, and that will give us a really good idea of what bugs are lurking around every month. And these are shed when you have a period. So oftentimes you don't actually, if you do a swab, it would be negative, but there could still be organisms, viruses, and that sort of thing in the uterus, which are causing inflammation, and you will pick them up in the menstrual blood. So I do that test now. It's called Hidden C test, and we can pick up quite a lot.
Is that expensive, Vivienne?
I think it runs at about £300 for that test.
Okay. And who would you select to do that test on?
I would do that on unexplained infertility. Okay. Yeah. Repeated failed implantation. So if you've had IVF before and haven't had implantation despite having very good quality embryos, And someone who's had a history of infection, perhaps. Someone
What
who's
about miscarriages?
Yes, and recurrent implantation failure, miscarriages.
Yeah.
I'm not so sure that it tends to cause a lack of implantation rather than miscarriage, I think.
Yeah.
The infection side of things, because it's inflammation in the uterus.
Somebody's just asking here, what do you think of the ERA, Emma and Alice tests? Are they worth it? Is Hidden C a better test?
That's a very good question. I know about the Alice and the Emma test, and they're very, very good. I know that's a very serious organization that's doing it. I haven't used them very much, so I can't really comment on them very much. So at the moment I'm using Hidden C, which is purely an infection thing, because my understanding is if there's an infection, there's inflammation. And if you can cure the infection, then presumably you'll cure the inflammation as well. But we can do Alice and Emma. We have the facilities to do that if it's something that you want to do. At the moment, I'm doing more Hidden C.
Okay. Okay, so another question here. Ovulation. I have 39-day cycles and ovulate, and I haven't fallen pregnant in 15 months. Could cycle length be an issue? Well, absolutely it can be. I don't know whether you want to answer that one, Vivienne.
And the question is, do you ovulate late and still have a 14-day luteal phase after ovulation, so time for an embryo to implant? What this lady needs is cycle monitoring to see actually when she does ovulate and what the lining looks like at the time, and whether she produces a nice corpus luteum, and whether the progesterone is good. There's a great deal that can be learned from one cycle of cycle monitoring with a couple of ultrasound scans. Yeah,
because it's very hard, isn't it, to check for ovulation, to do a progesterone test when the cycle is irregular.
If she's lucky enough to pick up an LH surge, that's a good sign. That's a good sign. But it still would be nice to correlate the follicle with the lining and the blood test to see that everything's synchronized as it should be.
Yeah, but also trying things like inositol and folate. Inositol is good at helping to sort of regulate the cycle.
Absolutely, to regulate the cycle.
Yeah, no, absolutely. Okay, is there anything I can do to increase my chances for my FET, my frozen embryo transfer treatment?
Well,
the embryos are there, aren't they? The embryos
are there. You'll need to have, I presume that you're doing what's called a medicated frozen embryo replacement cycle, where we give you tablets and pessaries. The usual things: keep hydrated. Acupuncture might help with blood flow. You'll be having scans to monitor the thickness of the lining of the womb, and they will only thaw your embryo if the endometrium is thick enough. They'll be doing scans to make sure you don't ovulate during a cycle, because timing is of the essence there. We need to thaw the embryos on exactly the correct day. But, okay, you've made your embryos and they're already there, but that doesn't mean to say you can go out and get drunk every night. Because
you've got to sort of be able to receive them.
You've still got to be in good form and take your folic acid and make sure that you're well nourished, even though they're...
How does an imbalanced thyroid affect egg quality? High TSH, low T4.
High TSH,
low T4.
Okay, so why? Well, the thyroid gland has an effect on metabolism of every single cell in the body. So the way each and every cell creates energy for itself. So it has an effect on everything. And if you've got an underactive thyroid, which is what this sounds like, with a high TSH and a low T4, then your cells might be sluggish, and egg quality can be affected by that. Your eggs may not have enough mitochondria, or they might not be working properly. So we would give someone with a high TSH a low dose of thyroxine to increase the effect of T4 and lower their TSH levels. And that sometimes is enough to improve egg quality enough to actually fall pregnant naturally.
Yeah, I'm always amazed how many young women, I don't know whether it was not picked up years ago, but the amount of women that come to the clinic that have got thyroid issues is quite high, isn't it?
It is high. It is high. Amazing. Thyroid disease in general, well, it's awful to call anything a disease, but it is. Thyroid imbalance is very, very very, very common.
Yeah.
And it's run in families as well. There are certain types of thyroid imbalance which run in families, but it changes as well. And just to remember, just because you've had one thyroid level that's abnormal, it doesn't mean to say that you've got a thyroid problem you're going to be on treatment for the rest of your life. It might be just a short-term thing, but we definitely need your thyroid to be in a certain condition for you to have the best chance of pregnancy and outcome for pregnancy.
So would you treat, if somebody's thyroid is low or high, would you treat, would you look at thyroid antibodies as well?
Depends how abnormal it is, actually, and the family history. If it responds to treatment very quickly, and we can very quickly get the TSH to come down with a low dose of thyroxine, then I wouldn't be looking for thyroid antibodies, because thyroid imbalance is it's a moving feast, and it can change very quickly. And often you can give a low dose of 25 milligrams and the thing sorts itself out. And I wouldn't necessarily go looking for thyroid antibodies in every, definitely.
Okay. So it takes about 4 to 6 weeks, doesn't it, to sort of do a retest and you see what is happening. Okay, but it's linked as well when you're trying naturally to maybe not ovulating. All sorts of factors.
Yeah.
Okay. Another question here, Vivienne. This is putting you on the spot. What would Dr. Vivienne's top 3 tips be to improve my chances of successful implantation?
What is this, in a natural cycle or is it in an IVF cycle?
IVF cycle, I would think.
Right. It depends on your age.
Yeah.
But if you are over 37, or let's say 38, I would hope that you'd been thinking about embryo testing to make sure that the embryo genetics were normal. Okay. If there's anything in your history which suggests that there might be either a clotting problem or an autoimmune problem, then you might have had some tests to make sure that there wasn't an immune issue going on, in which case we would give you extra help to make sure that the blood flow inside the uterus was good and there was no blockage to implantation. So that's important as well. But I think, to be honest with you, keep hydrated, keep moving, because that gets blood flow to the uterus up and keeps the circulation going. Embryo testing, and of course before. Was this a fresh cycle? Sorry, I've lost the plot a little bit.
No, it's just improved my chances of successful implantation. I would imagine with IVF.
Top is nutrition to start with.
Yeah.
Okay, to make sure that you're eating all the right things. But there's something to add in here, which is, hot subject at the moment, and that is the sperm. Because we're beginning to realize even more so how important sperm is. For years we've been saying, right, sperm, and if it looks good number, good motility, good shape, then it must be okay. But we're beginning to realize that it's much more complicated than that. And sperm may look okay, but in fact have problems inside. So if you have a history of miscarriage or repeated failed IVF implantation, then we should be looking at the DNA inside the sperm as well, DNA fragmentation. Yeah.
So we do that test as well, don't we?
We do that test, yeah.
In
people who've had unexplained infertility, recurrent miscarriage, repeated failed implantation, we would say, even with normal sperm, is there actually
Yeah. I think as well, Vivienne, haven't we got, aren't we doing a test now at the clinic to select sperm? Is it sort of zymote or something like that?
Yes, we are. It's not a test. It's actually it's a selection thing. So we're actually using it's very exciting. We are in couples who've had unexplained infertility or have sperm DNA fragmentation. We can actually select the sperm that they use for the IVF in the laboratory. It doesn't make any difference to the patient. They don't have to do anything different. It doesn't cost anything. And it's actually non-invasive. It's actually much gentler than the normal sperm preparation. And we make the sperm swim through a tiny maze. And the theory is that if the sperm can get through a maze, then the DNA inside that sperm head must be quite food. So we use those sperm to inject the eggs, and that's called Zymot. It's quite new. It's been around for a long time in America, and they're doing a very interesting, it's a 3-year trial. It's coming to an end at the end of this year. So we'll know whether or not it really does affect clinical outcome. I'm happy to prescribe it and advise it now because it's not invasive at all. It doesn't do anything.
Yeah.
And it's certainly not dangerous, and it doesn't cost anything.
But so, it can improve outcome, presumably.
Absolutely. We've seen already that, I've seen patients who've had previously poor quality embryos get better quality embryos in the end.
Fantastic. Another question here. Is there risks to the embryo with genetic testing?
Tiny risk. There always is. Anything you do to an embryo will have a tiny, tiny risk. So you have to actually hold the embryo and take a couple of cells from the outside of the embryo called a trophectoderm biopsy. And of course, they quoted at something like less than 0.1%. So it's there is always a risk in anything you do in the laboratory, but you have to weigh that up with the benefits gained from actually testing the embryos. That's from the actual procedure to get the material to test the embryo. Obviously, we now are better at diagnosing what's going on inside the embryo, and we can actually say whether an embryo is completely normal, completely abnormal, or whether it's what we call a mosaic embryo, which is part normal, part not. And we have a way of actually then investigating further and deciding whether that embryo should be transferred. But the actual physical risk is very, very small.
Yeah. And how many embryos do you need to have to be able to do genetic testing?
Well, you need one, basically.
Yeah, but you need a good crop of embryos, don't you, to begin with?
Well, that would be the ideal situation. But I know many women who don't have many embryos and will not get many embryos because they have a low egg reserve. But they've had perhaps some recurrent miscarriages and don't want another miscarriage. And they would rather collect one embryo at a time and do the biopsy and keep that embryo frozen, then batch their embryos. Rather than
that means doing more than one cycle, doesn't it, to be able to get the number to freeze? Yeah. Okay, we've just been told by my urologist my husband has ureaplasma in his sperm and was put on antibiotics. Could this be a factor as IVF has failed at 38, 39, AMH 8.5?
It could be, and presumably both partners had antibiotics. It's not so much the infection, it's the possible inflammation that the infection or the presence of microorganisms can cause. And if there's anything causing inflammation that causes microclotting in the uterus, then often giving a course of antibiotic for both partners might lead to implantation which hadn't already been there.
Okay, fantastic. Okay, is frozen sperm sample the same as giving a fresh one for an IVF cycle?
If it's good sperm, frozen's fine.
Yeah. Okay, fantastic. Who might benefit from DNA fragmentation tests, and are all methods of testing equal?
That's a good one. So who might benefit? Well, I think in the end, all will benefit. But for now, the alarm bells ring when we have unexplained infertility, poor fertilization, poor embryo development, recurrent miscarriage, and repeated implantation failure. We used to think that the egg could actually sort out everything, and it didn't matter. So long as the sperm fertilized the egg, we believed that the egg could regulate and repair lots of abnormal bits of DNA in the sperm. And the egg can do that to a certain degree. There are housekeeping, they can do that, but not all of them. And there are larger abnormalities that probably they can't deal with. So DNA fragmentation is important. And again, we have to know why has it happened? Is there anything we can do to improve the DNA fragmentation? And often lifestyle factors can improve it. And if not, or anyway, we can do this Zymot technique where we actually select the sperm, which hopefully have less DNA fragmentation.
Great. Okay. Would you recommend DHEA for a 41-year-old, soon to be 42, to help with egg quality? I do not have diminished ovarian reserve. My first IVF failed, as all I got 20 eggs, all fertilized, but failed to divide and grow any further at day 2. It's a bit confusing, this one.
Yeah, well, it's not so much the DHEA level. The DHEA is a bit of a marker of what's going on. What's important is what your testosterone level is.
Yeah.
The DHEA will increase your testosterone level to a good level. You need a little bit of testosterone, but not too much for good quality eggs. So it would depend on what your actual testosterone level is. If you've got a good high testosterone level, but not high, but a good range of testosterone, then you don't need DHEA. If you've got good numbers and a good testosterone, you don't need DHEA.
But also, it seems like her ovarian reserve is good for her age. It's
Absolutely.
just a bit odd what happened there. So it's going back, having a consultation and finding out what will be done differently next time around.
Yeah.
Okay. I would like to ask, when you are performing a hysteroscopy procedure, do you sedate a patient or not?
It depends on what you think you're going to find. If it's a procedure where you're just having a quick look, not expecting to find anything, and just a check, then you can do that without an anaesthetic. It's not very nice, but it's certainly something that you can do without any anaesthetic at all.
Okay.
A bit like period pain having a hysteroscopy. Whereas if you really suspect that there's a polyp or there's a fibroid or there's some adhesions in the uterus that will need to be dealt with, then it would need an anaesthetic.
Yeah. Okay. I have PCOS, hirsutism, irregular 30 to 60 day cycle, high AMH, normal testosterone, want to conceive naturally through IUI or IVF, possibly freeze eggs. Can I take myo-inositol to regulate ovulation without the risk of lowering testosterone?
Yes, you can. You can measure your testosterone first, take it and see what happens.
Yeah, absolutely. I mean, the hard thing with PCOS is you don't get an accurate reading of your AMH, do you? Because
it can be
having the
high,
condition. Yeah. And also doing IVF, there's so it's managing a protocol well as well, isn't it?
I'm going to move my phone a little bit to attach it to a charger. Sorry about this.
No, it's okay. It's okay. Are you running out of battery?
I think so. Strange, but there we are. Okay.
Oh, brilliant. Well done. That's better. I have been trying to get pregnant for a year, but no success. I have prolactin at 610. Is that okay?
It is. You know, they say 450 is the maximum. 610 isn't that high, to be honest with you.
Because sometimes it's in the thousands, isn't it?
Yeah, I would accept that as normal.
Yeah, but also prolactin is linked to stress, cycle irregularity, all of that. So it's managing those other factors as well. And I think just because you have one test, what's really important is that you retest, because we never go on just one test, do we? No, we always look at other tests as well.
You do a second test and it's completely normal. It would be low 450.
Yeah. Okay. Do IVF meds for women contain lactose? I have a lactose allergy. So I'm just curious to know if they would affect me.
There are some medications that contain lactose, and I can't for the life of me think of the list just like that, but we can certainly look it up. There are some medications. I'll have to look that up for you, but you have to be careful. Obviously, it's written on the label. Obviously, there are pills and things that contain lactose and Gynova, some of the things that we use for frozen embryo replacements. Obviously, the hormones for injecting don't contain lactose because they're purified FSH combinations. But some of the tablets can contain lactose, and some of the lactose is actually in the coating on the tablet.
Okay. Do all clinics test testosterone as a standard?
I don't think they do, actually.
No. I know we do free testosterone, don't we, for women that want to sort of look at DHEA and things like that.
Yeah, for DHEA, but in a general consultation, we wouldn't necessarily do it unless there was a reason to think that there might be a raised testosterone from clinical symptoms or the fact that there's PCO.
Yeah.
We check free testosterone,
Yeah. Do I have to redo all of my investigations if I come to a consultation at the clinic? Well, the answer is no, because it depends on if they're not more than a year. Is it a year, Vivienne?
Depends on what it is, but generally anything done within the last year is still valid as far as I'm concerned. Very important that you don't go and spend money repeating things if it's not necessary.
Yeah, great. Okay. Do IVF meds need to be bought at the clinic, or can I buy them from a local pharmacy?
You can do whatever you want. You can do what we have a very good
we don't stock the clinic. We don't stock at the clinic, do we?
No, we don't have any drugs in the clinic. We have a pharmacy around the corner, but we also have an agreement with a company who delivers drugs to your home or your office if you're in the office at the moment. But you can get your IVF drugs wherever you want. You don't have to get them from the place we suggest at all. No.
Yeah. Okay. And what are the different types of IVF, and how do you work out what's appropriate for each client?
Well, the different types of IVF depend really on your age, what's happened before, and the number of antral follicles you've got. So the number of eggs we're expecting or hoping to find. So a standard IVF cycle would be what we call a long protocol. If you've got lots of follicles and are expected to get a good number of eggs. If you've got polycystic ovaries or have a slightly lower number of eggs, we would do what we call a short protocol. And if you're someone who's got a really reduced egg reserve, we would do either a microdose flare or a natural or natural modified protocol. So it all depends on what's happened before, if you've ever had IVF before, and how many follicles we've got to work with.
Yeah, I think as well, it's interesting because a lot of women, when they hear the word natural, they're sort of drawn towards it, but it's not always appropriate for you, is it? And what that you're trying to assess when you see somebody, Vivienne, is what's going to give, what protocol will give the greatest chance of success to that person in front of you. Yeah, based on what you're seeing.
Natural, really, pure natural, rarely done. Natural modified IVF is for women with a critically low egg reserve, where if you gave them the maximum dose of stimulation, you'd still only get one follicle. So what's the point in giving that massive doses of stimulation? You go with a natural cycle and try and capture that one egg carefully, easily, without overstimulating the egg. Mild IVF, however, is a different thing. Mild IVF is where, even if you've got a normal egg reserve, and you don't need it, some women prefer not to have too high stimulation. And there's ample evidence that the embryos that we get from a mild stimulation, even though there might not be as many eggs, the actual outcome, the embryo quality and the pregnancy rates per cycle are as good with mild IVF as they are with a high stimulation IVF. So, it's
a lot of women as well, Vivienne, worry that with IVF they're using up all their egg reserves, and they get in a bit of a panic about this.
Yeah, so I always explain how the thing works. Got your little your supply, your store of eggs in the middle of the ovary, and then every month a whole wave of eggs comes to the surface of the ovary. It takes about 2 months to get there. And during an IVF cycle, all we're doing is using the follicles on the surface of the ovary that month to try and engage them in an IVF cycle. Next month, there'll be a whole new batch on the surface of the ovary. So we certainly aren't using up all of your eggs.
Yeah. And on a natural cycle, those follicles would just fall away anyway, wouldn't they?
Absolutely.
They wouldn't be recruited.
The naturally recruited egg, follicle.
Yeah. So anything you can do naturally to eat, you can do to eat to a lower TSH.
Oh, wow.
I don't think there is, because you can't replace a hormone with a hormone. You can only replace a hormone with a hormone.
You can't. No, I'm not sure there's anything you can take. I mean, in the olden days, we used to add iodine to salt.
Yes, yeah. But I mean people are short of iodine now, especially if you're vegan, not drinking milk, not dairy or anything like that. But then iodine is not great if you've got a high TSH, is it? With Hashimoto's, it can be.
That would make it make it worse.
Yeah, make it worse. Yeah,
but absolutely. I don't know of anything. Does sea kelp not help at all? Sea kelp?
I don't know, because that's got iodine in it as well, hasn't it? But a little bit is okay. I think this might be the same question. Anything I can do eat to lower TSH while taking levothyroxine, but the levothyroxine is going to lower the TSH anyway. Yeah. So Vivienne, we've come to the end. That's gone so quickly. Is there anything you'd like to add? Any pearls of wisdom you've got for these ladies today?
I the more and more, and I've been doing IVF for a long time, and there's always a balance between over testing and being accused of doing too many tests and wishing you'd done them if a cycle doesn't go well. And I'm getting to the point where I'm going to offer everybody everything that's available and say, I don't think you should do everything, but these things are available. These tests are available, because I see so many people who've done perhaps 2 or 3 cycles of IVF and without success. And then we say, well, let's just make sure that this isn't right. And let's just make sure. So there will come a time when we can offer all of those pre-IVF investigations at a good price, at a relatively cheap price, to make sure that when you do IVF, everything's in place and you've got the best possible chance. And lo and behold, if we do correct some of those things, if we find something that's not quite right and we correct it, you might not even have to do IVF in the first place.
Yeah, I know. It's amazing, isn't it? And I'm always amazed the amount of women, because like I was saying about consultations, women want to feel they're being proactive. It doesn't mean to say they're doing IVF, but sometimes if I say to them, right, we're in April now, why don't you book something for June, just a consultation, if nothing happens, and they sort of like relax a bit more, because they feel, right, okay, I'm proactive, I'm doing something, I've got something in the diary. They can cancel that appointment, they don't have to keep it, but it's just in their headset. I'm going to ask a couple more questions, then we'll go. So would you recommend banking embryos following genetic testing if you have one confirmed viable, losses on a transfer that didn't thaw well?
It depends on your age and how many babies you want. So she's saying she's got a normal embryo in storage, and she wants to know whether she should have
so. Would you reckon bank following genetic testing if you've got one confirmed viable? Yeah, I think so.
Well, it depends on your age. I know many people who are in their early 40s, they've gone through a round, they've got a normal one, and they say, right, no harm, it's in the freezer, let's leave it there. We would eventually like 2 children. We feel lucky. Let's have another attempt. Because if you transfer that embryo and you get pregnant, you likely will, and have a baby, that set you back by the time you've had the baby and breastfed. If you want to have baby number 2, you're a year down the line. And if you've done that IVF because of your age and because of your egg reserve, then you're in a worse situation. I know many people who've done a cycle, got a normal embryo, and said, you know what, I'm going to do another one. We'll leave that one there. No harm done. Let's try our luck and get another one. Baby number 2.
Another lady here, I remain scared to do IVF, even though I want to, if that makes sense. I totally understand that, because I'm always amazed. Sometimes women will go and do IVF and they'll come 2 years later and I'll say, why have you left it so long? And some of them have been really traumatized by what has happened the first time round. But I think that if you feel supported, and that's certainly what we do at the clinic, hand-holding support, if you have everything explained, it's never as bad doing it. The thought of doing it is always bad, but once you start to do it and you know the clinic and you meet the staff and you have a good consultation, you build confidence, don't you? Because I think the sad thing is to look back and have any regrets, because
and say I didn't.
Fertility isn't time friendly. Yeah, it's not time friendly, is it, Vivienne? It's really important to look at your age and the time, and it's very easy for time to move on, isn't it?
It's really easy for me to say, oh, just do an IVF cycle, because I've been doing this for such a long time. For me, and I really do appreciate how it's a big thing for people to do. It's a big commitment. It's a lot of time. But I want to get across to people that it's not scary. The biggest thing about IVF is it's expensive.
Yes,
and it might not work.
There's no guarantees.
And there's no guarantee. So,
but that's where the preparation at the clinic comes in, because if you feel prepared mentally, emotionally, you understand what you're doing, you're communicated with, you're able to get hold of nurses easily, it makes a huge difference, I think.
Yeah, absolutely. And if you've done a few extra tests, which just make sure that when we get that embryo, we're putting it in a place that is, happy and ready to accept an embryo, then I think that's a key thing.
Yeah. Vivienne, this has been so helpful.
Thank you.
This has been so helpful to the women.
Great.
Thank you so much. Got lots of likes and things. Could you make logistics work for a patient traveling from across the country? Actually, that's an important point, because many of our clients don't live in London. They come from all over the country, don't they? So we tend to do a Zoom consultation. And then how does it work, Vivienne, if somebody's in Scotland or Cornwall or...
It's difficult, isn't it? I've got a patient coming down from Yorkshire. That's not quite so far, but yeah, we can do as much as possible on Zoom, and then we can try to concentrate the active bit of the cycle, which is like, you know, 3 or 4 scans over a 1-week thing. You might even consider coming to stay in London. You can, if we're allowed to stay in B&Bs and that sort of thing. Take a week off and you just incorporate it into your life. But if you live so far away, to avoid the stresses of trains and being late and traffic jams, to actually just come and stay in London if you can. Make it a week, and you never know, theatres and cinemas might open one day, and restaurants and things.
But I think as well, it's important to get across as well, for many women, we do acupuncture, we do nutrition, we do hypnotherapy. You don't have to be coming to our clinic to do IVF to access those treatments.
Absolutely.
So
maybe
it's important that everybody's welcome.
We can, in you know, in some circumstances, we can ask a sister clinic to actually do the odd scan, you know, to see how things are going. It could be possible. It's not something we do a lot, but we could have what we call a remote scan. It depends on the circumstances, but an alternative.
If anybody's watching, absolutely. If anybody's watching this and wants to come along and see Vivienne, please get in contact with the clinic. Go on the Zita West Clinic website, and everything is on there. But thank you so much, Vivienne. I hope you all enjoyed today. And I will be back next week with more. But thanks, Vivienne, and you take care.
Thank you very much.
Bye-bye. And bye-bye, everybody.
Bye.